Welcome everyone. Really pleased you could join us today. As I say, this session is going to be recorded. Hopefully you've got an idea a bit about what this is going to be about. I'm Stephen Bow. I'm the chair of the Faculty of Public Health Ethics Committee and Special Interest Group. And my day job is as consultant in public health at West Berkshire Council, leading a small but growing public health team in the south of England. For those of you who don't know, the Faculty of Public Health Ethics Committee supports the board and all members of the faculty to identify and think through the ethical challenges arising from public health policy and practice. And it has a work plan to build partnership working, to support and educate the workforce, and to develop guidance and resources for public health ethics. The Public Health Ethics Special Interest Group, which I'd encourage certainly everyone to sign up to if you're not already a member, meets regularly, and I'll talk about some of the opportunities that are linked to the SIG later. So without further ado, I'm really pleased that so many people have joined us today to talk about the issues of ethics and equity that we've encountered in our public health practice, and to explore experiences of moral distress and consider how we might want to manage and respond to these issues. So there's an awareness, I think, that needs to be had around the distinctness of different types of ethics in public health policy and practice as we seek to meet the need and demand through education and training for faculty members and the professions nationwide. So the existing public health ethics literature is largely, comes out of academia and focus on academic audiences, and a lot of it comes from America, so it's quite US centered. So we see our role in the ethics committee as supporting the UK public health professionals and developing education and training materials that are relevant for the UK. I'm not an academic philosopher myself, so rest assured I'm not going to lecture you. I will give just a very brief sketch of what ethics is and what makes something truly an ethical question, not merely a technical one. This is really important, I think, because later we want to hear from you about some of the ethical challenges that you've encountered in your public health work. So we all need to know what we're talking about when we speak about ethics. So when we talk about ethics, we're talking about value judgments, good and bad, right and wrong, duty, rights, justice, equity, universal moral principles that sit underneath and behind all our laws and legislation, policies and rules. The quiet voice of conscience that always whispers and sometimes shouts. I'm sure that many of you have an idea of some of the ethical theories and key thinkers behind them. Now, don't worry, you don't need to know about all these various systems in order to think ethically, but their different emphases bring different insights about what is of ethical importance, which is what we really need to have an intuition about. So first of all, our intentions are important. Are we motivated by goodwill, doing our duty? This was key for Kant. And I'm sure we can all think of policies or decisions that are made or have been made where the motives might not have been pure motives. Undoubtedly, too, the consequences of our actions are important. For utilitarians like John Stuart Mill, they're all important. We might not go so far as to say that the ends justifies the means, but clearly we all care deeply about the likely outcome of our actions. And indeed, we have a whole science around logic modeling and evaluating outcomes, even if they're not the only thing that we care about. Ethics is also about our actions themselves, recognizing there are some things we should never do, some lines we should not cross. For example, we may feel like Aquinas that we should never lie to the public, even if that might be an expedient way to achieve behavior change. We also know that it's often hard to do the right thing, even when we know what that is, and doing the right thing becomes easier through repetition and practice, and therefore the need to work hard to develop good habits over time. Like Aristotle, we also recognize that the right course of action is often a balance, navigating the golden mean, the balanced path between two extremes. Ultimately, ethics runs through all of public health. We all recognize there are fundamental human goods or capabilities that all people, the whole public, want, And among these, we see that health has a special and prominent role, and creating the conditions for health drives all the work that we do. But at the same time, we acknowledge and support the other fundamentals such as science and education, liberty to work and be creative, building communities and families, and civic and religious participation. We know that good health relies on all these things, as well as supporting them in return. Having said that, though ethics is grounded in these real things, and so it's not subjective, our feelings are often really important signals about whether something's right or wrong. And when we partake or witness things that we think are unethical, it's only natural that we express feelings of distress. This might be called moral conflict, moral distress, or even a moral dilemma. There's also growing recognition of moral distress among health professionals, including public health professionals. Moral distress is distinct from stress or burnout and related issues. And aside from developing a shared understanding of what moral distress is in our profession, we also believe there's a strong connection between the difficulties dealing with ethical issues and experiencing moral distress as public health professionals. So please, as we're talking, just start to think about times in your work that you felt this, maybe the pangs of conscience, or even righteous anger. So just to draw this first section to a close, this is the first of a series of faculty events that will address public health ethics and moral distress separately and together. There'll be ethics special interest groups, special interest group events in the coming year, follow-up webinars such as this, education and training events around the country, development of regional ethics discussion groups, and perhaps we'll get to the end of this hour. This session's in two parts. The first part will be an educational approach, very briefly laying out public health ethics and moral distress. The second part will be hearing from all of you. And before we move to the two brief talks, we asked you to think about the following question and to put into the chat box the following. So the simple question is this: what ethical problem or problems are you dealing with or have recently dealt with? Feel free to answer the question as we're speaking or to reflect on it and enter later. But it's really important for our work that as many people as possible identify the ethical problems they're facing in their work so we can produce relevant resources to help. And just say we want this to be a safe space. So we'd like everyone to agree to Chatham House rules so you can share what was discussed but without attribution to ensure anonymity. And just to say, if you are putting any questions in the chat box, please put a capital Q at the beginning, just so we can pick those out. I will now hand over to Sridhar Venkatapuram, the Assistant Professor of Global Health and Philosophy at King's College London, to speak to us about ethics and equity problems in public health practice.
Thanks very much, Stephen. Hi, everyone. Good afternoon. Happy Monday. My name is Sridhar, as Stephen said. I am a full-time academic at King's College London. I'm also the vice chair of the ethics committee at the Faculty of Public Health, working with Stephen on a variety of aspects about ethics committee. What we're doing today, as Stephen said, and I'm just repeating the message, which is that this is the inaugural session in which we are seeking the members' ideas and input into ethical problems that they're dealing with in their work. And this is partly in order to be able to provide educational and training materials that are relevant to people in their work. And the reason that we're doing it this way is a separate, different way is to do it in an academic way where you essentially are given a textbook that says, here's what public health ethics is, and this is what you need to know. And what we're doing is taking a very different approach, which is that we are trying to build a corpus of public health ethics resources that are relevant to the people in the UK, but also through the process provide a sense of legitimacy that these are the ethical principles and ideas that are coming from people who are on the ground and as part of the community as well. So I'd like to spend this last 8 minutes that I have in order to rush through the history of public health ethics very quickly. Many of you might sort of be wondering or hoping that we are providing a list of ethical principles that public health should adhere to, and you're hoping that we give you a list that you can then go away with and saying, right, okay, here's what they've given us as the public health ethics principles. We are not going to do that. And despite the fact that the faculty, the ethics committee of the Faculty of Public Health has now some of the best thinkers on ethics, equity, and health justice in the United Kingdom, and we're very proud of this committee. We think that the way to do this is not simply to provide you with our wise opinion about what we think public health ethics is, but rather it's one part of a number of different ways of developing public health ethics. So I'm going to start us by taking a step backwards. For many of you, ethics is probably very familiar, and I'm sure you've joined today in order to let us know about what you think about various things. But some of you may be not so familiar and coming to it for the first time. But I'd like all of us to give me the benefit of the doubt and help me by taking a step back from this idea of what's the list that we need to know, to think much more about what is ethics in terms of the way that how does it help us, and also how do we come up with a set of ethics, etc. And this is important for a number of reasons. One is that many of us have very strong, clear intuitions about our work in public health. Many of us are driven to our work, many long careers, very difficult careers, very productive careers. But throughout it, we have a sense that we are doing it because of fairness, that somehow people should have the conditions for good health, that children should have opportunities for open horizons, that people should be able to live long and healthy lives. All these are ethical values that we have, and we also believe strongly in the notion of equity, that health inequalities are bad for a variety of different reasons, that constraints and limitations and hindrances that make people unhealthy are unjust and unfair, etc. All these variety of intuitions drive our work in a variety of different ways. And we often sort of rely on something very clear, is that we sort of rely on things that have happened before in order to be able to reproduce the same kind of policies, or we rely on scientific evidence and say the science tells us to do this, etc. I want you to think back and sort of say, the idea of relying on science and evidence is not only because science tells us what to do, it's because it's justification for our actions. So what you do is you say, we're going to follow this policy because it is, justified and the evidence supports it. In ethics, we also search in a similar way for justifications for what we want to do. Should we help these people or these people? What are the reasons that we use to help one over the other? And what is the justification that the reason is better or stronger? The second thing is that there is this sense of legitimacy that we're looking for. So when you see science and, sort of peer-reviewed evidence and corroborated with practice, that sort of provides you with this idea that there is relevance and legitimacy of what you're trying to do to the problem that you're trying to solve. In a similar way, ethics is also about relevance and legitimacy. So think about the idea that, there's ethical principles in a far off country that they develop for the way that they're going to treat a particular kind of health issue. And they are going to apply it. And then they sort of say, well, this is the right way to do things. And it doesn't match your values and your context. And so there is this problem here. Is like, well, who are they and why should we listen to them and what's going on? And so in that similar kind of way, we're also looking for legitimacy and also relevance to our problem. So, if I was to sort of say what ethics in terms of, when we're thinking about what kind of ethics to use and how do we use it and how do we develop it, I want us to first think about, well, is it sort of, justified? What is the justification for these kinds of ethics? Is it legitimate? So, how is it that we're developing these kinds of ethics for these policies that we're thinking about? And is it relevant to the problem? Is it fine-grained enough? Is it in the right area? Is it in the right zone? Or are we just applying it? So, why I'm telling you this in the beginning is that many of you are familiar with the medical ethics or research ethics principles. And if you probably have memorized them and you probably are sort of thinking about them on a daily practice and trying to say, well, how does autonomy work here and beneficence and non-malfeasance? Every healthcare professional in the world is told these four medical ethics or research ethics principles, and they memorize them and they try to practice them. But when you ask people, where did these four principles come from? How did you sort of, what is the legitimacy of these four principles? Is it actually working with the problems that you're trying to deal with? I guarantee you, throughout the world, when I ask these questions, most people do not know where these four principles come from. They think that they're ancient principles that have been handed down through medical practice, and that is not the case. These four bioethics, medical ethics, however you want to call it, principles that we are used to in healthcare are very useful, and they have been very useful in protecting individual patients and their privacy and their autonomy, making sure patients aren't abused and they're trying to deal with respect, and have helped us navigate difficult biomedical healthcare issues and interventions. What the issue here is that many people think that you can simply take these four biomedical medical ethics principles and apply them to public health. And it's simply not possible. And I've seen many examples where people try to say, okay, well, how do we do autonomy in this public health policy? And it just doesn't work. For the things that I said, is it relevant? No, it doesn't. The scope is not just one person, it's many people. Is it, sort of, does it seem justified? Well, where did these four principles come from, etc.? But there is two things that I want us to start to acknowledge and pay attention to, which is that the four bioethics or medical ethics principles were developed at a particular point in time in the United States in the late 1970s and 80s to deal with very particular kinds of problems. One of the problems was that public health programs, the Department of Public Health in the United States, was experimenting on various people for the sake of the greater good. They sort of assumed and said that the cost of certain people in terms of their suffering and disease was worth accepting for the greater good as well. And this was seen to be unacceptable anymore. But there's also lots of other kinds of abuses that were going on in healthcare. There was a greater sort of drive towards a notion of individual and patient rights as well. And then in Europe, you also were, there was also developing sort of different kinds of ethical principles as a result of the experiments that were done in Nazi concentration camps for the benefit of the army so that they could learn various kinds of things that the army could sort of benefit from these experiments, etc. While those four ethics principles are really important and worthwhile, you should know that they were an ad hoc list of ethics principles because there was not agreement on what the basic or foundational ethical basis should be for healthcare and providing healthcare or doing research. So you have autonomy and privacy as being really important because that's a very important idea in European Enlightenment, that the individual and their ability to reason and think is really important. You have the idea of do no harm, so non-malfeasance is really important. You have the idea of benefit as being really important because there was this idea that healthcare was being sold to people with no benefit, and that was something that was also good. But there was also this idea of fairness, that we should distribute healthcare across people in a way that's appropriate to their need, and that's the idea of vertical and horizontal equity. In public health, we are not just concerned about individuals, we're also concerned about populations. And so as a result, a lot of people think, oh, right, so what we care about is helping as many people as possible. So the greatest number is, what we're trying to aim. That is not what the way to go forward is. Unlike these four bioethics medical principles, and unlike in the United States, in the United Kingdom, we have a profound recognition that health and health inequalities, disease, mortality, etc., is not just determined by access to healthcare, but the way that we organize our society, the way that the environment is not only at a sort of very family, but also city, neighborhood, region, national, and international level. And so as a result, our notion of ethics and public health have to reflect our notion of what we think a good society is, how we should be improving our society so that it's fair and is sort of more just, not only in the domain of healthcare, but also in the conditions that help people have good health and good lives as well. So this is why there is no list of public health ethics principles that we're handing down, because we are at a point now where we need to actually develop those ethical principles that reflect our notion of what fairness and justice means in our society and how we're going to address health and health inequalities. So that's our aim in this sort of inaugural session, is to kind of point a, sort of plant a flag and say we're on the verge of building public health ethics, a corpus of body of public health ethics principles. And we'd like for you to help us in sort of being able to identify what are the problems that you are dealing with today so that we can use that, combine that with the knowledge of these wise ethics committee members, but also see what practice, see what the other academics are saying so that we can bring that all together to provide some information. So now what we're going to do is I'm going to hand it back to Stephen, who's going to talk about moral distress. And the bridge is that the ethical problems that give rise to ethical dilemmas that are difficult to navigate, is one of the major sources of the moral distress that people experience in the work of public health policy making and practice. So over to you, Stephen.
Thank you, Sridhar. Now, hopefully everyone can see my screen. So this is just to give a bit of a overview of moral distress. So appreciate that some people might know all about what I'm talking about, others won't. So this is just to get us all on the same page. So a couple of ideas here. First of all, the idea of a moral event. So that's some sort of event or circumstance which causes inner moral conflict or some thoughts or feelings that could be considered ethical or moral, as described earlier. Secondly, moral distress is the psychological distress arising from a moral event. So it's actually, the negative feelings that you experience subsequent to that. And moral injury is moral distress taken to its extreme. So it's the development of long-term physiological and/or physical symptoms caused by moral distress. So just take a step back. And it's easy to think of moral distress as something inherently bad, but I think if we reflect on it, we probably know that we don't actually want to get rid of all moral distress or injury because it does serve a useful purpose. And there's just a quote on the right-hand side here about the absence of moral distress in the nurses involved in some of the Nazi experiments that Sridhar was talking about earlier. So actually, the fact that we're experiencing moral distress can actually be a sign of a healthy conscience, rightly ordered intuitions and so on. Just to get a little feeling of sort of how it arises. So obviously this is our starting point. So we all have a conscience, we have moral integrity, we have a sense of what's right and wrong. And then something happens, a moral stressor. So it creates some inner conflict with our beliefs and feelings. And it might be minor, it might be major. And this causes initially some moral stress. If it's minor or we feel capable of navigating, it may only be stress. It might just be something that energizes or excites us, and then we move on. That could become moral distress as the intensity increases, and then over time that could develop into moral injury. So what can we do about it? There's, as with any sort of health harm, there's multiple points we can intervene or treat. So first of all, we can look around sort of the our situation before. We can help people, help professionals in public health to build emotional resilience, and also provide ethical training so we're well equipped to deal with morally challenging issues. Then, of course, it's possible to avoid uh, the causes of moral distress. If bad things are happening, let's stop those bad things happening. Um, so that's another thing that hopefully moral distress will draw attention to those things, and a natural response to that will be to reduce them where possible. Um, then, in terms of experiencing moral stress and moral distress, um, it's important to raise awareness of what it is, so people recognise that they're experiencing and why they might have these feelings. It's got a name. It's got a science and evidence base behind it. And then for people experiencing moral distress and moral injury, there's various evidence to support the benefits of peer support and therapy, extreme and psychological therapy to deal with moral injury. And talking about the workplace and public health profession, employee support programs of various kinds may help with all of this. So excuse the cartoon, but I think it's worth flagging there is a risk of backfire effects with the two areas that I pointed out. So ethical training works both ways. I think it's clearly helpful in equipping us with the skills and tools to navigate thorny ethical issues and puts us in a better position to get through them successfully. At the same time, there's also evidence that those who have been trained in ethical thinking also are more likely to analyze issues ethically and therefore experience more moral distress because incidents that they would have just happily sort of gone through unawares in the past. Now that they're thinking ethically, they're identifying sort of moral concerns, and that gives rise to more moral distress than they would have before. So I'm not at all arguing against ethical training, by the way, but it's just something to bear in mind. And then, of course, addressing the causes of moral distress. Often, if the moral stressor is an unequivocal evil thing that's happened, then of course we want to get rid of those things. But actually, a lot of experiences of moral distress that people report are from equivocal situations or issues that don't have easy solutions, and to solve them in a simplistic way could have knock-on effects, causing harms elsewhere. So it's not necessarily straightforward to do. Finally, just to give a sense of some of the reports of moral distress and injury that members of the faculty did experience through COVID, and we ran a survey a few years ago, and possibly many of you will have taken part in. These are some of the findings. Happy to share the report with anyone who's interested. It wasn't a necessarily representative sample, so the percentages are more indicative, but it gives a sense of the scale of the types of moral distress or conflict people experience. But really interesting that this is the situations in which moral distress arose around developing and implementing national policies, giving public health advice, and also workplace relationships and environments. Some of the moral judgments that led to distress were causing injury to others, or conversely, the feeling of inaction or inability to do good. Also, dishonesty in public health messaging and unjust prioritization decisions. And then there were a suite of suggestions of how to address moral distress, better decision-making, communication, participation, practitioner moral development and support, pandemic planning, resourcing, and so on, freedom to voice concerns and conscientious objection, and also the sense of acceptance that sometimes there is no mitigation possible and we just have to accept the distress that we're experiencing. This is to give a flavour, and this was obviously very specific to COVID, and it'd be interesting to know if similar themes arise in general public health practice, or if there are different things that people experience. So I'd like you to have a think now also about some of the maybe experiences you've had more recently in your public health practice that have, um, you know, given rise to feelings that you might characterize as moral distress. So hopefully that's helpful. We're going to move on now to the listening or conversation session. So thank you for everyone who has put something in the uh, chat already. And we want to, as Sridhar said, we want the work of the ethics committee and the SIG to be oriented to the issues that that you are all facing in real life. So we don't want to develop a textbook about niche scenarios that might be theoretically interesting but are relevant to public health practice. So we really want to hear about the things that you're struggling with ethically and support the analysis and debate around them. Therefore, this is the question we're posing. What is an ethical problem you're facing or have recently faced in your professional public health practice? And likewise, if that's trigger distress or moral distress. We also want to hear about what brings you to the webinar today. Have you experienced moral distress, where you felt forced to do something you felt was wrong or prevented from doing something good, or felt pulled in two different directions by competing moral demands? We're looking for contributions verbally and in writing. So if you've got a question for the speakers, as I say, please do put a Q in front of your comments so we can easily pick them out. So I haven't been monitoring the chat, so I don't know if we've got any hands. Otherwise, Sridhar, was there anything that that anyone has
Yeah.
said that you pick out?
Yeah, a couple of things have come up that I find important. I think one of the things that's distinctive about public health ethics is that, particularly in the UK, public health professionals have to work with politicians and often are managed by politicians to some extent. And this creates a number of different conflicts where political reasoning or politicians may be interested in particular kinds of outcomes or don't want particular problems addressed, while public health reasoning might be sort of pulling in a different direction. So some of the comments that are coming up are really about these two different ways of thinking about health policy. So a political sort of approach in politicians versus what the public health professional feels is the right thing to do or should sort of stand for. If anyone has any specific or particular comments or ideas about that, I think that's a really newly identified issue. I can tell you that many of the academic literature does not address this problem because academics don't work in policymaking, so they don't realize that they are, sort of governed by politicians, etc. But this is something that became very clear during COVID, and it's also coming up now, I think, for many of you who are working at a city level or a regional level. So I think this is a really important area that we need to think about. A second area that is, common and very familiar is about priority setting or resource planning, which is that many public health policies, are meant to address certain kinds of problems, which mean that they benefit people of different kinds. And so priority setting is actually choosing which people will get the benefits and which people do not. And this creates a lot of different tensions for people. On the one hand, it might be, sort of very epidemiologically driven, but on the other hand, it might be more cost efficiency driven. And this seems sort of counterintuitive to ideas about fairness and equity that people have. So that's the second sort of idea. The third sort of thing that's come up from reading is that there is a strong intuition here that public health policies should be geared towards those who need assistance or interventions the most. So it might be people who are most ill or most at risk or most vulnerable, or it might be another idea of, the poorest people in a particular area. So there's a pull towards helping the worst off, but this may not be what the politicians want, or it may not be what the other public health priorities want as well. So that's what I've heard or understood or interpreted so far. I welcome anyone else who has some other interpretations of what's been in the chat so far, but also to identify certain kinds of ethical problems that they are struggling with or they have identified. And I understand that it might not be comfortable to speak about experiencing an ethical problem. This is one of the things that Stephen and I want to change, is the idea that just like in a medical setting where you go to a group or a committee and say, there's this difficult decision I have to make and I don't know what to make it, that is not an embarrassing situation. That is a recognizable, difficult situation. And it's, an ethics consultation helps you think through that. And what we'd like to do is create an environment in public health that we also are able to present, hey, this is a decision that I have to make, or this is something that I need to do, or I'm faced with, and I'm not sure what the right thing to do is. And that's something that we should respect and actually be able to recognize as a difficult space that we need to think through together. So this is the first one. Let's see how it goes. Hopefully, if you need to, you can speak in the third person. You can talk about your friend who's having a problem. So that's also fine as well.
It's really interesting to see how many comments there are and how varied they are as well. I think there's some sort of issues that you might have predicted, but also some less expected. I'm surprised actually. Maybe it's just my bias working in local authority that there's not more mention of the use of public health grant and resource allocation, which perhaps that's because I know that various local authorities do have ethical frameworks and you feel well equipped to make those sort of funding and defunding decisions. I can't see any hands, so perhaps everyone's happy.
Oh, there is a
Proceed.
hand. There is a hand. I see a hand.
Oh, there is. Oh, wonderful. Uh,
Jessica,
Jump
sorry.
in,
I
please.
hope you don't mind me using first names.
That's
I
fine.
apologize. Yeah, yeah.
No, no. I'd rather you called me Jessica rather than Mukherjee. I have put it in the chat, but my moral injury, I suppose, is the substance misuse grant. I lead for substance misuse in Kent County Council and have done for many years. So through longevity, I was at the table when we made the decisions to reduce the grant by 1 million during the time of the cuts in 2013, 2014. I knew at the time that was going to result in deaths. And yet, at the same time, we were banging on about inequalities and, early mortality and, carrying on business as usual, which is the job of public health in a local authority. I don't want to be in that position again because we spent the next 10 years campaigning to get that grant put back. So there's some kind of faculty kind of understanding about, and I put the word idiotic in the chat because it just seems morally chaotic, let's put it that way, to not have some position that this is actually going to have direct impact on people's lives next year and the year after, as opposed to in 20 years. Yeah, so that's what I wanted to, and maybe a position around that and advice to directors of public health as well, who are often in that position, actually.
Yeah.
Thank you. Yeah.
Could I
I was just
comment
going
on
to say
that?
before you come into it, I think what's my reflection is it's really interesting that you've described that as a moral issue, which I think is really important that we should be willing and able to make the moral case for or against decisions, which uh, is not always comfortable, maybe, but I think it's important. Sorry, Sridhar, please.
No, no, not at all. No, thank you very much for raising that and for bringing that. I would like to make a point here, which is that we have significantly under-recognized the moral stress that public health policymakers, some public health policymakers, implementers face as a result of knowing that it's not just one death of one patient, but it's the death of many people in the community. That I think has been very severely under-recognized as a burden that public health implementers and policymakers carry. We often have recognized and we talk about the great distress that individual physicians face when they have to deal with life or death decisions of one patient, but we have not given enough recognition that actions, whether we follow them or don't follow them, will sort of impact large numbers of people or many people. And they may not be easily identifiable. They're not all sitting in front of you, but we know that this is going to happen. And as time goes on, you will see who those people are. And this creates a large mental and psychic burden on public health officials, particularly when it comes around funding cuts. And I think we need to recognize that more in as a sort of an ethical burden that people in public health carry. And we need to help people become more capable of carrying that burden and being able to recognize when they will not be able to, feel satisfied that they're able to do that very well because of lots of different kinds of things.
Sridhar, we have a question in the chat. How should the new public health ethics framework incorporate law as well as politics? Don't know if you want to have a stab at that. I've maybe got a bit of a view, but I don't know if you've a hot take.
Public health framework. What's the public health framework?
I'm assuming it's what you were articulating about the need to
All
develop
right.
sort of
Yeah.
the work that we're doing.
Yeah. So how should public health ethics incorporate law? And what was the second thing?
As well as politics.
As well as politics. So there's the politics question is really interesting. I think many of you who work in public health policymaking and implementing are likely to be very strategic thinkers and actors, and you see what your political environment and your surrounding political environment is, and you try to figure out how you're going to be able to manage different kinds of situations. What we are doing with ethics is separate and it's more internal, where you, as an individual and as public health professionals, we sort of figure out what the right thing to do is in terms of equity or fairness or justice. In terms of how you achieve that outcome in ethics, in your political space, I think is a different set of skills, right? That's political strategy and skills, and I think that's a separate one. We are sort of more focused on the reasons and how you reason through and what are the different kinds of reasons for taking action as well. I think law is another really important space. One, I think laws reflect ethics of a given point in time. And what we want to do is we want to, follow the law at all, sort of points that we can. But as you know, as we are seeing, there are good laws and there are unjust laws. And so ethics sits outside of the law. And so what we're trying to do is give you the fire of ethics that will allow you to run the machine of law or run the machine of political strategy. And so that's sort of the way that I think about how ethics, law, and politics relate to each other.
Yeah, I'd agree with that, Sridhar. And what is it? I think an unjust law is no law at all. I think it's the classical saying. Um,
We just have to be careful of that because, many people are public servants here. So we never told anyone to break any laws, just to be clear.
I think it's really interesting in the chat. Actually, there's a lot of questions that do resolve to that tension between our professional roles and our consciences, and
Yeah.
I think it has come up in various recent conversations as to what the role of conscience is, and how we ought to um, respond to that. There's also a question, I think it's rhetorical in the chat, from Siobhan. Can any aspect of public health practice be free from moral injury, given we're already making choices within parameters? I think that's fair. But I think it's rhetorical. I think the answer is to agree with that. Woody, your hand's up. Do you want to speak?
Right. It's a follow-on from what Jessica was saying about people with drug addiction. But the focus of today's meeting has been generally on population-related ethics, fairness, evidence, that sort of thing. The deontological, if I've pronounced that correctly, ethics of the red lines you won't cross. And that was really the key thing with the Nazi nurses who were mentioned earlier. They were quite happy in the old asylum system in Germany to arrange for the killing of 80,000 patients just in Prussia, people with chronic mental illness, because they were seen as less human, less valuable human beings. Now, in two areas that I've worked in, drug addiction and learning disabilities, there's a very, very strong inherent systemic, structural prejudice against these people getting equal attention. It's very difficult for them to self-advocate with organizations and institutions. And I can remember with the head of the Metropolitan Police, he's saying things at a public meeting about the drug using patients that I was working with at the time, just dismissing them as having status. Okay? They didn't count. Why bother about them? They're never going to change. And they've internalized the criminality which society affords heroin users. So I wonder if, Stephen, you have views on how we can ensure that we don't so marginalize some groups. And I think people with intellectual impairments are an obvious one in our society. There have been many reports. They just tend to fall off the cliff when it comes to health planning. And I put something in the chat about working in Essex and encountering prejudice is too mild a word, dismissal of migrants and refugees within the authorities. They just didn't see them as deserving recognition and help. So would you like to say something about how we can ensure that future public health professionals, I hope that Sue Atkinson is still engaged in this because she had very strong views from her past work about not writing off anybody. What do you feel about that, Stephen? How can we ensure that we don't cross red lines like those German nurses in the 1930s?
Thank you, Woody. Yeah, really good comment. I think there's probably just briefly two things. One is as Sridhar said, ethics is about the internal pre underlies our decisions and precedes law and policy. So it's about equipping the public health workforce with the training and knowledge to understand ethical issues and hopefully identify that one and respond correctly to that. But then also, I guess, as public health professionals who are influencing or shaping policies and developing rules and laws, legislation to ensure that those do concretize those ethical intuitions and principles, and ensure that those vulnerable and marginalized groups are protected. That's just my response. But Sridhar, it looked like you wanted to say something as well. I don't know if you wanted to come in.
No. Sorry, I was just fidgeting. I apologize.
Oh, okay. Getting a bit behind on the chat because there's so much going on.
So it's becoming clear that people are more comfortable writing in chat, but I encourage you, this is an extraordinary showing. There's 73 or people that have shown up today. Clearly, there is a great interest in the topic of both public health ethics, but also moral distress. But we have to crack the nut in terms of figuring out how to get people to be able to speak about different kinds of ethical issues that they are dealing with and want sort of help dealing with, or they think public health should be dealing with. But the comments, if you feel free to continue to put things into the chat. It's really important that we try to start opening up a conversation in all the different kinds of different difficulties. It is undoubtedly requires courage in this space, and I have no doubt that many of you have that. But I want to say that I understand that this is a difficult space and it's new, and it's not a lecture you come to listen to, and so we're asking you to participate. Jessica, again, please.
Well, I've been around a long time, so I can say something, I suppose, like Woody. We've been around a long time, and I suppose that is one of the things that we can talk about. So when I started my public health career, when I was sort of in my late 20s, I would be much more prone to soaking up what the culture was of an organization, of what the profession. But as you continue, you can see the long game. So the reason another reason that I mentioned the inpatient detox is because 10 years later, it was undone because it was seen as a thing that happened that was morally injurious to a group of people. Now, that's not the only example. So I suppose what I'm saying is, if we can build in a resilience from the beginning in terms of training, that actually you will meet this. We are only as good as the government that is, public health is only ever as good as the government that it works for, unfortunately or fortunately. So how do we equip a workforce to kind of understand that? I mean, that wasn't the first moral problem that I encountered as a young public health professional. There were lots. Why is a voluntary sector organisation just dismissed out of hand when another one is given money doing it? I remember thinking, that's a weird decision. I don't wonder who makes that. So it's equipping future leaders, I suppose, because it's when we get into leadership positions that we can then be much more influential. And I would say then it was the cadre and the quality of public health professionals that were around subsequently when they saw what was happening to substance misuse services that kept the pressure on. So then you become an advocate. I suppose what I'm trying to say is, let's start from that position that we will be facing these. How do we equip ourselves? How do we equip ourselves for advocacy as part of our role as well?
Thank you. And if everyone's happy, we'll leave that as the last question, I think, because we want to wrap up on time. I just wanted to briefly talk about next steps. And just going to share my screen so you've got the details. So just a bit more about the Ethics Committee and Special Interest Group. As I say, this is the first of a series of events. We want to have more meetings like this and delve into specific topics. I mean, there's lots of really sort of thorny issues that were raised today, and we'd love to do some deep dives and webinars and discussion sessions on a selection of these. So the information you provided, hopefully it'll be okay with you, that will reflect on this by the Ethics Committee and feed it into our work around training and education and other efforts. We will the special interest group, I'd highly recommend you to join if you're not already a member. If you're interested enough to join this session, then there's a very low barrier to entry. You just need to be a faculty member and be interested in public health ethics. You don't need any special training or credentials beyond that. We'd love to hear your voice. And the next special interest group at 4 p.m. on the 27th of January, we've got a guest speaker, Professor Peter Littlejohns, the founding public health director of NICE, and he's going to talk about NICE past, present and future. We've also started training for public health registrars, which will be rolling out over the next 2 years. And we're also really interested to hear if other professionals and consultants and practitioners and the wider workforce would be interested in CPD sessions around public health ethics. We're really open to contact around that. We're also developing resources that will be going onto the website, and we'll soon be launching a newsletter for public health ethics, and we'll share details of how to sign up to that in due course. We're also open to receiving any follow-up from this event, issues to consider and comments, so please do drop us an email if you are interested. So any last words from you, Sridhar?
No, thank you all very much. I am just absolutely thrilled that over 70 or so people have taken off their lunch to join us. It really shows us and reaffirms that people are interested in both sort of public health ethics, but also moral distress. And I promise you that Stephen and I are trying and will do our best in order to build on this and to sort of both build more events, but also resources and training and whatever. So we are available to stuff. There is a hand up. Yeah.
There is a hand. You can have the
Well,
final word, Nico.
If I may, no, it doesn't mean to be a final word. It's a practical question. How is it possible to view the recording? Is it possible to share the recording with colleagues? And will the chat be saved within the recording? Something like this.
Good question. I'll defer to our support, Tallulah, from the faculty. I don't know if you're able to answer that, Tallulah, about how the recording will be available.
So the recording will be available in the FPH portal. I will share a link to that with a kind of feedback, and then we can share the chat if possible, if that's what was wanted from the organizers.
So yeah, we'll share the chat. Sorry, we'll share the chat while taking away the names from it. So we'll share the points, but not the names of the individuals that provide the chat. Sorry, Tallulah, go ahead.
No, perfect. That sounds all good. So I'll share that alongside the feedback form.
Wonderful. Thank you. Thank you, everyone, and have a lovely day.
Thank you, everyone. Bye.